So he ended the first part by asking the question, so what? We didn't achieve anything in terms of the E. coli bacteremia, so what did we achieve? Well, I hope you have had the opportunity to review that video, How Wolves Changed Rivers. And in there, although they talk about a cascade, in truth, this is a system being influenced by an agent being introduced into that system. So it is an illustration of complexity science on a grand scale, albeit Yellowstone National Park. So what happened from our point of view? Well, we started the narrative reporting in September 2014, and a year later, the laboratory manager in Carmarthen just happened to say one evening, we seem to have an awful lot less urines than we ever did previously. And that chance observation was what started us looking at the urines that was never going to be our endpoint that we would measure. And what we found was that across Howell Dar, where we'd had 7,000 urines per month from the 3 laboratories, we'd gone down to 6,000 urines per month at the end of the first year. Not only that, when we then examined the 2 years before we started and collected 2 years worth of data after and put them into a change point analysis program, we found that in retrospect we could detect a change about 3 months after the introduction of our new way of reporting from September 2014. The negative urines had shown this drop seen on this slide. But as we said before, we went on with multiple initiatives as well going on, particularly from 2016 when we started the Bevan Commission exemplar program, and we had multiple initiatives going along across the various teams that we challenged. And so when we introduced further changes, again from the start of 2016, we found a further drop about 3 months later. A year later, our pharmacist had a large program of GP auditing, and again, within 3 months, there seemed to be another drop. But the other side of the house was that the positive urines, although they're dropping, at this point, they did not seem to show any form of statistical fall from where we were before. So what we were seeing was a drop in the negatives, but the positives being maintained. And that, of course, means that the positive to negative ratio has improved, gone up. So we're now seeing more positive urines, but we're taking out largely the negative urines. Not only that, in retrospect, we think we were seeing an improvement in the quality of the clinical information on the request cards, and our PA did a specific investigation looking at one GP practice in September 2013, a year before we started the program, versus September 2017, quite a way into the program. And using a scoring system, we showed that the clinical words associated with UTI, so dysuria, frequency, pain, etc., were appearing more frequently on the 2017 request cards than ever occurred on the 2013 request cards. Not only that, as a result of the orthopaedic audit, the decision was taken that we no longer needed to have urines being sent in as a pre-op investigation for patients who had no signs of UTI and were going forward for implant surgery, because audit showed taking the sample did no good. They spent a lot of time trying to clear the organisms from the bladder, which normally failed, and therefore we were able to stop the cancellation of operations, remove an inappropriate intervention, and move the whole scenario forward. From a GP auditing point of view, when we went into practices to audit, we found that we were able to reduce the use of all types of antibiotics for UTI. So how can we go about spreading this innovation? Well, in 2018, we offered to support our colleagues in North Wales who were unable to fill consultant locum posts. They were therefore struggling, but we had somebody we could appoint down in Hywel Dda, took on a fifth consultant and said, we will now take on your urine authorization. What we predict is that with your sample size of 15,000 urines per month, we should be able to, after a year, get you down to 13,000 urines per month, which in other words means that there is going to be a reduction of 24,000 urines per month in North Wales. And that's exactly what we demonstrated. And again, having started in August, the change in retrospect was discovered by 3 months later, by November 2018. Additionally, the quality of the clinical information improved on their request cards within 3 months. Now, the savings from a laboratory point of view are modest. However, if you do an opportunity costings exercise and look at the reduction in resource wastage by way of people not doing various samples, taking out GP appointments, taking out antibiotics, as well as the laboratory costs associated with investigating a urinary report, then we estimated that the resource release for Hywel Dda in that first year's worth of, where we gone down by 12,000 samples per year, was £145,000 release. When we introduced it to both North Wales and Hywel Dda, that's number 3 and number 6 in terms of the geography of Wales, then we'd gone from 12,000 specimens reduction in Hywel Dda plus 24,000 specimens reduction in North Wales. And by the time we got this far, Hywel Dda reduction had doubled. So we were seeing a reduction in 48,000 urines not coming into the laboratories of North Wales and Hywel Dda, with an opportunity savings or opportunity release, cost release of over £500,000. If we to replicate this across the UK stage, then the opportunity release is going to be £31 million. The holy grail of all of this is antimicrobial resistance. Now, while we have not yet been able to demonstrate a reduction in antimicrobial resistance, the data to the end of 2019 for Hywel Dda shows that while there were 2 stepwise increases in resistance to urinary antibiotics before we started the program, from September 2014, there is no evidence of further increases in Hywel Dda. Not a reduction yet, but clearly that's part of what we're trying to achieve with this exercise. There is, of course, collective learning in this, and I introduced you to this book by 3 psychiatrists from America entitled A General Theory of Love. And this is where they're looking at people who are unlucky in love and why they continue to be unlucky in love, and the processes that are going on in the brain. And this introduced me to a whole new area of understanding about how the brain works. Not unrelated, of course, to people's relationships. This is more about the generic learning from this. We learn through education, and education remains a mantra. But what I now understand is the way we learn depends upon which part of the brain is being impacted. When we are undergoing didactic teaching, this sort of talk here, the aim is to introduce that knowledge into the cortical brain. It's the so-called head knowledge, and we can know lots of things, but whether we do lots of things as a result of that is not because we've got it in our cortical brain. Rather, when we develop insight and experience, we develop and we own the actions that we learn about. This insight and experience requires the limbic brain to be engaged, and then in the limbic brain, as something impacts with you emotionally, you make a direct new synaptic connection in the brain. It's like switching on a light bulb. And once you got to that point, that stays with you until something overrides it by taking you to a different place in relation to the same piece of insight that you have. And while there was this constant talk when we were younger that once we get into our 20s our brain starts to atrophy, that may be true of the cortical brain, but the limbic brain continues to grow. Two studies that illustrate with this. The study by Woolett and Maguire is one where they did serial MRIs on trainee London taxi drivers who were trying to learn the knowledge. And the knowledge is the ability to recite standard routes within a 5-mile radius of Charing Cross, the quickest route between two places. And it can take anything from 2 to 4 years to learn the knowledge. And what Woolett and Maguire showed was that with their serial MRI investigations, that the hippocampus expands in these individuals. Marino Jimenez and colleagues were looking at the brains of older members of the population, either those who were active and had a normal brain function versus those who had Alzheimer's disease or dementia of other origins. And they found whereas the normal elderly brain continues to expand and develop in the same way in the limbic brain, those of the dementia sufferers stop growing. So this experiential development in the brain is ongoing while we're in that learning phase. So 3 take-home messages from where we're coming from. Healthcare is a complex adaptive system. So tools that are used from a complexity science point of view can be used in healthcare and will give bigger gains when we are able to demonstrate to people how we get the behavioural change around that ownership within the limbic brain, as we've been seeking to do through narrative reporting. And narrative and storytelling is very much an underestimated tool, although it's a developing tool. Number of times now where during educational sessions we're asked to emotionally engage with somebody's story, not least from a patient's journey or patient story point of view, helps us to get the understanding cemented in our limbic brain, and for some there will be an instant change at that point. For others it will come at a later time. But narrative and storytelling seems to be key, which is why the exercises we're going through now in moving to narrative reporting in microbiology, I think, is so important and will lead us to public health gains going forward. We couldn't have done this without the engagement of the Hywel Dda University Health Board, the board members themselves allowing us to explore complexity science, and the Bevan Commission for assisting and funding with some of the activities we're involved in, and of course my colleagues in the Infection Prevention and Control team and my fellow consultant microbiologists in Hywel Dda.